Good morning, distinguished speakers, respected moderator, honored guests, and dear participants. On behalf of the organizing committee, it is my pleasure to welcome you to International Webinar Series to commemorate the 80th anniversary of the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, in collaboration with Friendship Indonesia and the Southeast Asia Regional Association in Medical Education, or SEARAME. Title: The Future of Medical and Health Professions Education. My name is Divarama Fitria. I'm a dentist and currently studying Masters in Medical and Health Professions Education here in Universitas Gadjah Mada, and I will be your host for this event. We are honored to have participants joining from various institutions and countries as we engage in scholarly dialogue on the evolving landscape of medical and health professions education. And to begin the program, let us sing together the national anthem of the Republic of Indonesia, Indonesia Raya, please. Ladies and gentlemen, we are very sorry that we have a little bit of technical issues. Please wait a minute. Thank you. Thank you, everyone. It is now my honor to invite the Dean of the Faculty of Medicine, Public Health and Nursing Universitas Gadjah Mada, Professor Dr. Yodi Mahendra Datta, Master of Science, PhD, FRS, to deliver the welcome address. Professor Yodi, please.
Thank you. Is my voice audible?
Yes, clearly.
Okay. Good morning, everyone, distinguished speakers and partners from Friendship Indonesia and SEARAME, respected colleagues and participants from around the world and across Indonesia. It's a great honor to welcome you all to this international webinar commemorating the 80th anniversary of our Faculty of Medicine, Public Health, and Nursing here at Universitas Gadjah Mada. For 8 decades, our faculty has been dedicated to educating health professionals and advancing the health of our society. Now, as we mark this milestone, it's also important for us to look forward to how health professions education must evolve in response to rapid technological change, global health challenges, and the growing need for professionals who are not only competent, but adaptive, collaborative, and socially accountable. So this webinar provides an important platform for shared learning and international dialogue on the future of medical and health professions education. And for that, we are deeply grateful to Friendship Indonesia and SEARAME for their collaboration. And we extend our sincere appreciation to all distinguished speakers who have generously shared their time, expertise, and perspective to enrich this forum. Now, allow me to open this webinar by reciting a poem on reimagining medical and health profession education, a poem written by a final year medical student, which is an honest reflection of hope, struggle, and aspiration from within the journey of becoming a medical doctor. So the poem goes like this. Since class 8, the dream took flight, to be a doctor, to heal, to fight. A white coat shining, a heart that mends, a journey of service that never ends. The white coat rests upon my frame, but nothing inside feels the same. An endless syllabus, expectations tight, a first-generation medic lost in the night. We bow to cadavers in anatomy's hall. Through formalin winds, we endure it all. Journals copied, deadlines near, but is this learning or just fear? Attendance is marked, yet minds drift away. Who sees the student absent that day? Good grade hide the battles inside, mental health mask with nowhere to confide. Patients reduced to bed number 29, not a frightened child with a story assigned. We treat the fever, discharge the pain, but the cause outside still says the same. And so we ask, what should it be? Not just 19 subjects and a degree, but growth of mind, of heart, voice, an education that gives us choice. Professors, not celebrities rare, but mentors with wisdom, presence, and care. A system that values listening and guide, not just marks that students hide. The white coat holds sweat, blood, and tears, a trial of courage, a fight through fears. I dream of a path where we heal, not just try, to serve with compassion, to ask how, what, when, what. May this reflection remind us that the future of medical education, health profession education must be shaped not only by curriculum and technology, but by empathy, humanity, and the voices of our learners. Thank you very much for your attention.
Thank you very much, Professor Yodi, for the inspiring remark and also the wonderful poem. And before we begin the academic sessions, allow me to briefly introduce today's program and our honorable speakers. Today's webinar brings together international scholars and leaders in health professions education who will share perspectives on emerging challenges, institutional responses, assessment strategies, and regional experiences in competency-based education. Our speakers for today include Professor Alvina Supe, and then we will have Professor Ova Emilia, and then we will have Professor Simon Gibson, and the last session will be presented by Professor Ham Peters. Before we begin, allow me to share a few brief reminders. Ladies and gentlemen, please keep your microphone muted throughout the session, and participants are encouraged to submit questions via the chat box. And the Q&A session will be conducted after the presentation, and the session will be recorded for documentation purposes. It is now my distinct honor to introduce our moderator for today's webinar, Professor Dr. Titi Savitri Prihatiningsih, MA, MEd at PhD. She is a professor in medical education at the Department of Medical Education and Bioethics Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. She previously served as the Dean of the Faculty in 2012 and as Vice Dean for Academic Affairs, demonstrating her long-standing leadership and dedication to advancing medical education at institutional level. At the national and regional levels, Professor Titi has held several prestigious positions. She served as General Secretary of the Indonesian Association of Medical Education Institutions, or IPKI, from 2007 and 2011, and as a council member of the ASEAN University Network Quality Assurance from 2013 to 2017. She was also a member of the Indonesian National Education Standards Board, or PSNP, from 2014 to 2018. Currently, she serves as the president of Southeast Asia Regional Associations in Medical Education, or SEARAME, reflecting her strong commitment to regional collaboration and educational excellence. And in addition to her extensive leadership experience, Professor Titi has contributed as an international task force member in accreditation and social accountability, bringing global perspectives into medical education reform. And she completed her PhD at the University of Dundee, United Kingdom. With her remarkable experience and expertise in medical education, accreditation, and quality assurance, we are truly honored to have her guiding today's discussions. Ladies and gentlemen, please warmly welcome Professor Titi, please.
Okay, thank you, Dr. Diva. Good morning, afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh. Distinguished speakers, respected colleagues, ladies and gentlemen, it is my great pleasure to welcome you to this international webinar entitled The Future of Medical Education and Health Profession Education. We gather today at a transformative moment in the history of health profession education. Medical education is evolving rapidly, shaped by advances in technology, artificial intelligence, global health challenges, shifting social expectations, and the growing demand for accountability and quality assurance. These changes requires us not only to adapt, but to reimagine how we educate future physicians and health professions. The future of medical education is no longer solely about transmitting knowledge. It is about cultivating adaptive expertise, professionalism, interprofessional collaboration, digital competence, and compassionate patient-centered care in an increasingly complex healthcare environments. We are truly honored to have distinguished experts who will guide us through this important discussion. Their insights and experiences will help us navigate both the challenges and the opportunities that lie ahead. Let us begin this session with open minds, collaborative spirit, and a shared commitment to advancing the future of medical education. We hope that today's webinar will provide not only theoretical insights, but also practical perspective that can be applied in our respective institutions and clinical setting. It is my great pleasure to introduce our distinguished speaker. The first is Professor Afina Supe. Right. Wow. Professor Dr. Afina Supe, he has so many degrees. He was Famer Fellow in 2002, and also Master in Health Professional Education from University of Illinois, Chicago. He has extensive experiences as a director, clinical government in Hinduja Hospital, also as past president, past secretary in various organizations in India, as well as at the regional level. He's also founder director of GSMC Famer Regional Institute, and currently he serves as a postgraduate recognition committee in World Federation for Medical Education. Without further ado, I respectfully invite Professor Afina Supe to deliver the presentations. The floor is yours.
Thank you, Dr. Titi, for such a generous introduction and wonderful beginning. Can I share my slides?
Yes, of course, please.
Okay. 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 Can you see my slides?
Yes, and also very clear voice.
Okay, great.
Thank you.
Thank you, Titi. I think this is a wonderful idea and wonderful topic. So I really appreciate and thank and invite for this invitation. And I'm going to speak on global trends and challenges in medical and health professional educations in the around here. Now, I would like to thank Dr. Titi for her invitation. And I must tell you at the outset that this PPT is not prepared by artificial intelligence. I think we have to now declare this conflict of interest. Thank to my colleagues in FAMER and India and also my institution. Now, I think COVID pandemic and surviving world is something which made a major change into the educational policies across the world. All of us have survived through the COVID, but we also had a lot of impact on medical education. So what happened during this particular time? The global medical education is shifting towards technology-driven, competency-based, and interprofessional curricula to address 21st century health needs, yet it faces a rapid but uneven change. Another change which has really happened, which I think your dean very rightly said, we are shifting from the knowledge base to the skill and attitude based, and that's what we should really remember. Now, if you really look, what is the scale and growth of global medical education? Global market valued at a huge amount all over, and it's projected to go almost double in next 10 years. And if you really see, Asia Pacific region is experiencing the fastest growth, all, if you see your countries are really growing tremendously in this field, and growing investment in the health professional training worldwide, and increased public-private partnerships and government funding initiatives. To give you an idea, you look at the growth of medical colleges in India in last 7 years. In 2017, we were about 400, less than 400, and now we are 818 medical colleges. So we are sharply rising. Even government is also increasing. And I think if you really look at the trend around the world, many countries are having such kind of a trend of medical education in India. And if you really see, this is something which is, we have to be concerned also about the quality, but we have to really look. So if you look at these particular papers which have really come, trends and challenges of medical education in changing academic public health environment, and these are quite recent papers, another like say exploring trends and challenges in global health medical education. And then you find global perspectives of trends in higher education. And this was one classic paper which came in 2024 by Professor Harden on the future of health professional education. So what we'll do really, we will not only look at our own perspectives, but also look at the published literature which has come around on this topic. So what are the transformative trends? What is really changing into this particular thing? The first thing, technology and enhanced learning, AI integration. I think in spite of lot of ethical issues or lot of restrictions, students have started using. Last year, we realized that 83% of students in UK were using AI for their various in higher education. And I think the same trend is in the health professional education. We cannot really keep aside what is happening. Secondly, because of the COVID, we have a lot of hybrid and flexible learning modes. Classroom modes have now not the only modes, and didactic cognitive load is not the way. Now we have a lot of hybrid and flexible learning models. The third is because the numbers of students have increased and ethical issues, simulation based training is now important for competency based. And interprofessional education has also been realized is one of the most important aspect because people have realized the teamwork is so important, and taking everybody together, whether the nurses and the other members, is so important while you are treating a patient. And this is something which was a weak point in many institutions. I think this is being emphasized now more. Competency based education has been now worldwide because people have realized that if you make students learn only with the cognitive load, you are likely to have hyposkillic doctors. So it's important that we emphasize competency based education, and all over the world there are different ways of being putting, and I will discuss this more here. So let's first talk about technology enhanced learning. Okay, how AI integration has been really part of this technology based education. So adaptive learning platforms have come into picture. Personalized education. Now, most of the generation Z and the millennials want a personalized educational pathway. AI-powered diagnostic training, what we call as in learning analytics and simulation, they have become very common. You have to really give a proper feedback to them. Virtual patient interactions. Now, this is one new area where we have now scripted virtual patients, avatar-based virtual patients, intelligent tutoring systems, and competency-based assessment with automated feedback. I was very happy to see there was a talk on competency-based assessment. Now, one thing that changed is the emerging technology. Simulation labs have become very common. Now, initially, they were low key or low fidelity simulations where there were people used to use locally, which are still used, but they are mainly used for simple tasks. As the years have increased and the experience has come, now we are using complex tasks being used by complex high fidelity simulations. Now, if you really see, we started cadaveric labs way back in 2000, and we first published our paper in 2004. And that time we used cadavers for about 9 or 10 specialties, including laparoscopic surgery and everything. We used to use our anatomy dissection hall for all this. But now there are state-of-the-art cadaveric labs, which are used for various kind of purposes, from organ donations to vascular anastomosis. Everywhere you will find cadaveric labs are very common for practice. Now,
meanwhile, these students are performing the same surgery, but on an artificial lung. On the left, the real operation. On the right, an organ created by them. A success. The tumors are removed and it's time to compare.
Now this is
Doctors make the final touches to make
The operation.
Now, if you see, this is 3D printing. They are creating a complete replica of the patient with the pathology. And when the surgeon is operating, his students are operating on that particular 3D printed model. Now, this is a real experience of simulation. Nowhere close. They just seeing what steps they are taking and then they are cutting. That's the way students learn more. So that came rise to the extended and mixed reality. I think augmented reality, mixed reality, and virtual reality, with from low immersion to high immersion, which came.
Placement.
Now,
It's closest to the pink zone. The rectum is closest to the red zone. So our green zone in the midline is the one with the greatest safety zone with both the ureter and rectum at safe distances.
Well done. In what direction would you place the suture? Speak the color of the correct arrow.
When we're placing sutures, our area of maximal control is the entry point. So we're going to put our entry point from lateral to medial, as that's going to be closest to the ureter. So I'm going to choose the arrow from lateral to medial, or the
now look at this girl. She's trying to learn how to prevent ureteric injury while doing any surgery. And then this is where she's looking at it and then she's trying to put stitch. Now, this kind of an reality training helps students to take them much more. So if you look at impact of AI on health professional education, practically every aspect it has come: curriculum, teaching, learning, education management, students monitoring, as well as assessment. Everywhere you find it has really come. So what has happened in the current landscape? AI systems increasingly appear in clinical and educational settings. There are so many levels people are using it. Medical schools are adopting curricula to include AI literacy. Now, this is very important. Every medical college should have an AI literacy, AI curriculum, which should have AI literacy to everyone, including faculty. There should be an ethical use policy for every institution. So students should use it and they ethically and responsibly use it. And there should be now ifs and buts and checks and should be there to see how students adopt to this AI. Growth of AI powered learning tools and simulators. There is, if you really see, this has been completely last 5 years, completely changed. Emergence of AI native students, most of our students today are AI native. Everybody is using now chat GPT is a very basic thing, but now there are a lot of people who are using academic chatbots and blurring lines between educational tools and clinical decision support. Having said that, simulation-based learning has completely changed with the virtual reality and augmented reality. There's interactive simulation has come, like allows real-time interaction between users and simulated environment. Now, if you really see this AI Harvey, which has really come, now, if you really see, this is one which talks also,
The group is going to be understanding the same reality. So now the instructor can really focus on how to manage a complication. Nothing ever has provided that level of information. It's not a textbook, it's not a video, it's not a PowerPoint presentation that's going to give you that kind of understanding. CA Healthcare selected shoulder dystocia as the first scenario on Lucina AR because it's a rare complication of delivery, but it's one that's difficult to manage. You have a number of options, you need to think fast. Seeing the anatomy, seeing the progression of the baby in the birthing canal, and seeing where the shoulder gets stuck is going to be very helpful to understand how to fix it. Seeing them in front of your very eyes as a student is like a revelation, right? This is the future of healthcare education. Really beyond the spectacular of that experience, there's an educational purpose that we're fulfilling. And that
now look at the way they do. Now, this is something called as an avatar-based virtual patients. Now there are patients who talk about their specific patients. Somebody will talk about osteoarthritis consultation. Somebody has a suspected bowel cancer. You can talk to these patients. And most important means the whole system will give you a feedback. They will tell you where your questions right. Did your pauses were right? Did you ask a proper history? I think students can really learn and they get a wonderful feedback. If you just go in PubMed and you really try to type just avatar-based patients, you will have 230 more than that papers. And that's the way kind of people have been doing research. Mixed reality, I'm sure there's going to be a talk, so I won't really talk, but this is something from real environment to virtual environment. And there are large virtual 3D images are for learning, interactive and sharing. If you really look like this, you can create a liver image like this, and I can hold it, I can rotate it. And so exactly I know now that which vessel I have to cut when I'm doing a surgical kind of an education. Now, what is more important is that I can use these images for intraoperative image guidance. I can really hold it by the side. I can use the 3D, and then now I am operating. And when I'm operating, or my assistants and all, they come to know which vessels I'm going to cut. And this becomes your guidance while even operating. And that improves not only safety of the patient, but also helps you to learn, make people learn how they are going to do. And this use of technology and newer methods along with current teaching has enhanced the competence and pool of the surgeons. That means that it's a great learning point. Now, AI has come in assessments also, simulated patient encounters, provide personalized feedback, evaluate theoretical knowledge, evaluate diagnostic and procedure skills. Now, the question is, should we permit students to use AI during assessments? I'll leave this to all you to think. I'm not going to discuss this. But what is more important is improved performance with learning analytics. All our students learn with this learning performance. Now look at this deep image analysis. For example, if you want to really see how your student is doing, you can take the videos of your students and put it into deep learning, or this is convolutional neural network. And students, they will analyze and they will give your students instrument detection, like they will really recognize whether the tool has been used well, if the instrumentation is very good. So the students get a feedback saying that whether their hand has stabilized or not stabilized, and that the way they differentiate who is a novice, who has become an expert, and then they quantify your educational pathway. Gamification is something which has come very popular. Students remember and understand new and complex information instantly. Even simple undergraduate basic sciences games, people play anatomy, physiology to pharmacology. Gamification has often great help, especially also helpful in crisis resource management. So you will find, So you will always find that this is something, and we have tried using this over a period of time, and AI and HoloLens is something which we tried to use for outreach programs in Nepal. We tried to treat the Nepal remote places with these kind of hepatobiliary surgery. Now, this was a wonderful scoping review of artificial intelligence in medical education in BME guide, and this says that what is the level of thing you can really do. And this was recently came last year, and you can really tell you how many acts you to do. This is on easily available, but it also gives rise to ethical considerations of medical education. It also tells you that though AI is good, it has issues about transparency and informed consent. It has automation bias. It has cyber security and confidentiality. There is a human interaction and compassionate care issue, though now I think AI is talking about more empathetic also. Safety and quality assurance, resource allocation of equity, and bias. And all these are to be considered when you are using AI. So if somebody wants to use responsible use of AI, knows how is very well used today, but shows and does, still the chatbot will not help. The next issue which has really come in a big way is a competency-based education. All over the world for last 15 years, there has been a wave of competency-based education. The ultimate goal of CBME was curriculum and assessment, which ultimately, if you do, that is called as a quadruple aim, better outcomes, improved clinical experience, improved patient experience, and lower cost. And that was where the competency-based came. So what happened actually shift from time-based to outcome-based curriculum and defined competency framework like CANMATES, ACGME milestones, and competency-based assessments and progression. So all over the world, different kinds of competency frameworks were published. This was EP, a double MC came with the curricular developers guide. India came with its own volumes. Then UK came with the various kinds of guides. And everybody, like say, they were program level competencies like EPAs, institutional goals in our National Medical Commission. Then course level competencies like subject goals. Then topic level goals like objectives. And there were activity level goals like milestones. So if you really see all over the world, like say USA came out with milestone project 1, milestone project 2, Europe came with EPA, now they're all merging. And India had its own way of really objectives, but now it's coming towards similarity. But there was a lot of variability in the competencies. So the key challenges included difficulty in framing competency objectives, overlapping content in the various kinds of factors, limited faculty training, and inadequate support for simulation-based training, and misalignment between student priorities and curricular goals. And notable enablers were small group teachings, simulation-based sessions, well-organized timetables. And if you really see, there were a lot of infrastructural constraints, inadequate staff, their training in the new methodologies, and poor interdepartmental coordination. Now, these were issues found in many big countries and institutions because there was a sudden change into the competency-based education. Another thing which came was hybrid and flexible learning models. Blended learning combining in-person and online components. Now there are, most of the conferences have an online component, most of the meetings and sessions have online component. Students have this and faculty are getting trained. When COVID started, very few people were trained into doing this, but now I think everybody is trained. Asynchronous learning has again become a global accessibility. Somebody is working in Japan and somebody working in San Francisco now work together. An asynchronous learning. When you do these courses of MHP or in various British or US in universities, and when we are working from Southeast Asia, we always find we have to follow the asynchronous learning. Expanded reach to remote and undeserved regions. I think whenever a country is very large, this hybrid and flexible learning, we can reach much more people in the remote. And of course, we can continue to do our CPD. So hybrid learning modes added face-to-face online, personalization, learning because it gives you feedback, personal feedback. You can have a lot of social, though there was a social distancing at that time, we could maintain that. And there were flexible schedules. And there were a lot of remote learning tools which really came with that. So what did blending learning compared to the traditional learning? These are the papers which came in COVID times. They did a lot of systematic review and meta-analysis. And what did they do? They said that hybrid and blending learning had significantly transformed medical education by integrating traditional face-to-face with digital components. And it indicates that superior knowledge acquisition and improved clinical outcomes. And that was their overall review. But if you really see, we have to have a hybrid model which probably works better. The another area which come in a big way, and that was interprofessional education. Collaborative learning among health professions. Team-based practice separations. People have, though interprofessional education was known, it was never implemented in a big way. It was only on paper. But now I think people have realized that attitudes and skills are most important. And the teamwork. And this is where a lot of effort has done. If you look at our own Indian curriculum, which was mainly cognitive and knowledge based, we tried to shift it to skill and attitude based. We in fact introduced the whole ATCOM module, attitude, ethics and communication. And we introduced across India 800, and in fact now it is being used many countries and other aspects also like nursing and para health and all everywhere. So that was something where we realized that if everybody learns this, then converting into interprofessional education, people will be ready, because the main problem of interprofessional education is the egos and attitude. So if you are able to change that, And that change has been seen all over the world. And we are now seeing enhanced patient care outcome through this. So if you look at this review from British Medical Education, this is, and what does it say? Towards global partnership model in interprofessional education for cross-sector problem solving. I think wonderfully written. In Asia, interprofessional education is rapidly evolving from isolated initiatives to mainstream component of health sciences curriculum. And I think in 2016, FAMER started one new FAMER Regional Institute, which is specifically for IP, interprofessional education. And then when that was a kind of an innovation, when it started, everybody was a little wondering, will it really be of a help and survive? But now after 10 years, you find so much of usefulness of such kind of initiatives which have really come, and people have realized the value of this bringing IP into the mainstream components. Driven by the need for patient-centered care in aging societies and a push for improved patient safety, the region is seeing significant shifts to how healthcare professionals are trained. So when you start using IP, definitely there has been an improved patient safety. So there were 6 trends into the health professional education in interconnectedness, interprofessional education, then longitudinal integrated clinical education, more patient, community, and NCDs. NCDs are growing all over. And we need to involve community for lifestyle changes, NCDs, and all that. Then partnership with patients, families, and communities. We have to expand our health education not only to the medical colleges, but to the communities. And that is something interprofessional education is going to bring it. Lifelong learning and long-term well-being. Today we are not only talking about hospital education. All over the world, the ages of living are growing. People are talking about longevity research. Many people want to live now 100 years, and that's the reason why lifelong learning and long-term well-being are very important. And then you are a shift to competency-based time variable and the needs of the society. This is where you find education is changing. And integration of artificial education intelligence and a new educational and information technologies. These are some 6 trends which we are seeing, and this is where we are getting connected with each other. Now, what are the other key trends in medical education? Increased focus on social determinants. Education is pivoting to address health equity, community focused, population health needs rather than just individual patient care. We are talking now much wider in our health education. Global health and mobility. Another issue which has come is we are expansion of our international collaborations, exchange programs, and digital connectivity, what I call as borderless medicine. That is because today there is so much of dearth of people, health professionals in many European countries, many other countries where there are now going to be migrations of people from the health professionals, especially nurses, other health workers, where there are aged population in the Europe and there are no people for them to take care. So they're all looking for health professionals from Southeast Asia. So we have to create our people who have a global health and mobility. Our curriculums have to adapt to their curriculums. And another core challenge in education is outdated curriculum. What do I mean by that? Many institutions struggle with traditional didactic and fragmented curriculum that do not prepare graduates for modern healthcare. It's time that these curricula need to change every 5 years, and we need to add all these new components, and we have to make our students globally competent. We need to make them for community oriented. We have to make them technologically evident, and we have to make them competent. So it's a huge amount of challenge for the whole system to adopt, and that is where we are still struggling. And inadequate funding, and global investment in health professional education is still low. You go to any country, they don't give money for education and health. And for health, education is not a priority in many countries. So often comprising less than 2% of their total health expenditure. Most of the politicians are busy in building bridges and they are building infrastructure and their own agendas. But when it comes to the health professional education, agendas are not so good for all of us. And lastly, but not the least, is the quality assurance and accreditation. We have to really see that even uneven standards and weak accreditation mechanisms in many regions. So we need to have now the whole concept of World Federation, when they started basic medical education and advanced medical education, they were trying to see, like say PGME and BME and CPD, they were trying to see that at least there are basic standards across the world. And for the basic medical education, we have achieved quite a bit. But now postgraduate medical education, which has started only last year, and I am the member of that, and we realize there are only few countries which are starting, but I'm sure over next 5 or 10 years, there are many more countries will go for the postgraduate medical education accreditation. Another challenge which remains in all of us is a faculty development. We need to train faculty to use new technology and pedagogic approach. We as in National Medical Commission in India, we invested a huge amount of time and energy and funds to develop faculty. And over last, say 15 years, we almost developed 1.5 lakh faculty in medical education and in various areas, with the new curriculum, then their advanced course, and now we have so many courses which you are doing, which is a very positive trend. Otherwise, we had to go to US or UK to get a degree. But now I think many of the institutions can get it in India and or in Southeast Asia, and then we can really train our people better. There's a health system disparity, which is another common difficulty in adopting education to rapidly changing healthcare models, such as moving from hospital-based to community-based. So if you look at the other emerging challenges in the field, our mental health is growing. We need to work on mental health, not only of the community, but also stress and burnout among students and professionals. Antibiotic resistance, we don't have new antibiotics now. Climate change and health, addressing health impacts of environment changes and conflict of interest of ensuring transparency and ethical standards. So in fact, we recently wrote a paper on educating tomorrow's doctors on climate change, artificial intelligence, and providing care to the aged population. So if you look at Dr. Harden's paper, what he talks about reforms, innovation, and trends. He talks about future of medical education. And he talked about technology-based education, outcome-based education, that is competency-based, interprofessional education, fit for purpose workforce. He's always say that we should create doctors which will be community ready, and changing role of students. Don't underestimate. Our students have to change. Students as clients or consumers to become partners in learning programs. Okay, this is a change we want to see. Students have to take their own responsibility today, their own ownership of their own education. And this is a wonderful kind of a book they published, Changing Role of Medical Students. Changing role of medical students as information processors, facilitators of learning, and curriculum collaborators. So AI and education management has come today, which probably gives you many things like adaptive assessment, predictive analysis, personalized pathways, gamification. And so to summarize, because I have finished 30 minutes, this is the last minute, so I will summarize today. Global challenges and trends. If you really see, there has been a rapid expansion of schools with variable quality. We are expanding tremendously all over the world, but we have a variable quality. All of us should strive for accreditation quality in our institution. There's a faculty shortage and development gaps. I think in spite, because of such a rapid expansion of schools, we are finding faculty shortages in many countries. There's a curriculum overload, but the relevance has to come. Our students must learn what is relevant to them and take away things which are not necessary. And training for population health mismatch. This is something which we need to train our people for community ready rather than just as an experts. There has to be assessment and competency in implementation challenges, digital transformation and AI integration, simulation and skills training in equity. There is an inequity from government and public-private situations. And most important, we must emphasize professionalism and ethical training in our system. So another thing is students' well-being and mental health, interprofessional education barriers, equity, diversity, and inclusion challenges, and global workforce mobility and brain drain. We have to really see all this. So what is the last message I want to give? Embrace technology while staying human. This is the new future of health professional education. So thank you so much. And I would take questions. Hope, Titi, I am in time.
Okay, thank you very much, Prof. Avinas, very much on time. You have delivered a very comprehensive and insightful presentations on global trend and challenges in medical and health profession educations. A lot of issues you have discussed about the trends and the challenges, the technology enhanced learning and AI integrated, hybrid flexible learning models, simulation-based learning, interprofessional education, and competency-based medical educations. Now I would like to ask Diva, could you inform the questions? A lot
Yes,
of
Prof.
appreciation. Yeah, please. Yeah. Okay, this is from Dr. Idam from Palu, Indonesia. First of all, I would like to express my sincere appreciation to Professor Avinas Tupe for such an insightful sessions on the future of medical education. Regarding the integration of AI, specifically learning analytics, could you please provide examples of how its application is evolving for both undergraduate students,
Sure.
preclinical, and those in clinical rotations? I'm particularly interested in how we can use this data to bridge the gap between theoretical knowledge and real-world clinical competency.
Perfect. I think thank you
Thank you.
so much, Idham, for asking this question. See, what has happened today that now let's take a simple thing like history taking. If I want to take a history taking in a difficult patient, today what it is, hello, can you hear me?
Yes.
Okay, so his question is how do we integrated AI into learning analytics? Now, when my student is taking a history and I want to give him a feedback, whether he asks right questions or whether he has what is his voice quality, what is his knowledge, what language he has spoken, did he ask correct questions? Now, today you can easily he can go to Google AI Studio, he can create a case, or there are so many online cases he can interact with them and it will give along with him he will give a feedback. Now teachers initially can teach them, then he can go to Google AI Studios and many other these avatar based patients, he will get a feedback and he will come to know where to really improve, and then he again can go back to the teacher. We could have this sandwich or a hybrid technique by which he can clarify with his teachers and he will get his own personalized feedback with AI. So this kind of simple thing I'm telling you. Then another thing is when you're teaching preclinical, many times it becomes boring. You can use AI to create questions, gamification, so that the students remember and you bring a clinical relevance to the whole thing. You don't have to really take patients now. Everything can be really done online and the students get a relevance and they learn better. So that's the way you integrate now the theoretical knowledge with real clinical competency. Now, something I'm doing is like say skill, they are giving a simple injection, or I'm really doing. Now, this all can be done with easily with digital simulation, and the communication, digital simulation, clinical reasoning, clinical communication, all this can be easily learned. And if you want, you can go to my YouTube channel. My YouTube channel is Avi Supe. I have so many talks on AI practically given at many parts of the world. So you can really listen to my talks on AI in clinical decision making, AI in education, and I'm sure you will in various specialities. So you can really learn how you can really combine this for the training and education.
Thank you. So you have a YouTube channel on AI. This is very
So
good
it's my
information.
YouTube channel, but there are a lot of lectures on AI. So you
All
can
right.
really listen to them.
Okay, so anybody who want to know further about AI in education,
Or you can write to me. I'm sure I'll give you a lot of examples.
All right. Thank you very much, Professor Avinas. Any other questions, Diva? Okay.
Yes, Prof. Yeah, we are trying to show it on the screen. Yes.
Okay, thank you. The second question is from Dr. Siti Hadiza. Thank you for the presentation, Professor Avinas. Do you have any suggestion on how to develop a sustainable curriculum that could suit a rapidly changing health system? Please.
I think that health systems are changing tremendously. So we have to change our curriculum every 5 years and take a review. the more problem in our curriculum is how to cut down and throw away unnecessary curriculum, how to make choices. Most of the people will only add their curriculum. I think teachers have a responsibility of saying this is not very common. We can keep it for self-learning and we can tell them about the important parts. So in these kind of things like climate change, pandemics and all this, we need to really include them. How to take care of aged, AI, that need to be given importance today. How we use technology and how do we use technology in community for reaching community. So we need to change the focus of our curriculum. So we have to do it every 5 years, or I mean that is where currently the curricular change has to happen. Now, I don't know whether he wants to ask sustainability, but sustainability is a very big issue, and that I think we may not be able to discuss it here.
Okay, thank you. For the next questions from Dr. Gadjah Listiana. Thank you very much, Professor Afina Supe, Professor Titi, and all participants. My name is Gadjah Listiana from Indonesia. I'm currently a student at Gadjah Mada University. I have a strong interest in the development of artificial intelligence, which has also become the foundation of my current MHP thesis research at Gadjah Mada University. With great respect, I would like to address my question to Professor Afina Supe in the continuum from low immersion artificial reality to high immersion virtual reality. How do we determine the optimal level of immersion for different learning objectives without increasing cognitive overload for the students? Thank you.
Sure, it's a good question. What I would say that yes, how do you increase the without increasing the cognitive load? Remember, we have to use their existing curriculum and see how we are making it easy for using this AR and VR. I think low immersion ARs are easily available. There are a lot of free tools which you can really use it, and like simple cognitive tools. And high immersion VR costs a lot of money. So you have to really see what is available to you. And then if you are going to use all this, it should be part of your existing time and you should replace your existing time and see that if there's a particular thing, how will you change it? Then only you will be able to achieve what you want to really say. Otherwise, what people say, they add as an addition. Don't add it. Replace your lecture with these kind of activities. And then once you do it, and then look for the outcomes. These are all innovations. And these are all teaching learning innovations which most of the national bodies will not object.
Thank you, Professor Afinas. So good day. You may contact Professor Afinas directly about the artificial intelligence. Is there any questions? We still have a couple of minutes.
Yes, one more question, Prof.
Okay, from Dr. Galuh. Thank you, Professor Afinas, for considering the high rates of stress and burnout among medical students. Do you believe that technologies such as digital platforms and virtual reality can meaningfully reduce mental health burdens, or might increase technological integration unintentionally add new forms of stress, such as digital fatigue or performance pressure? What should educators prioritize to ensure that technology supports rather than harms students' well-being? Thank you.
Sure. I think students are definitely stressed out and burn out more today. I can see there is a need for mindfulness and changing the environment. But digital environments like this one thing, they are available 24/7 to the students online. And therefore, that makes most of these students happy. But what is important here is that when you are introducing these kind of things, give them a personalized feedback to improve, and give a feedback in an appreciative way. And of course, the digital fatigue is a problem. Many of the students continue to see mobile and all that. So we need to have that, what you called as an screen time, or there is a screen zero time sessions, and these kind of their habits and behaviors need to be implicated. And performance pressure, yes, there are performance pressures, but as an educator, we could really use technology to reduce their performance pressure rather than bringing a competition. For example, you try to see if the normal students are doing in their own way, then don't disturb them at all. Those who are underperformers or something, there only you support, so that and you help them personally, so you have a personalized attention to improve, and others can work on their own performance and they get a feedback. So there is no performance pressure to almost 90%. Only those 10% who have a performance pressure, you help them with a personalized help. And that's the way I think you can really look at students' well-being. In fact, all these digital tools and AI can help students. You can recognize whether the student's mental health is appropriate. Today it can really find out if the student's responses on digital technology are not good. They can identify the student is stressed and it needs a special attention. Now, there are enough amount of literature and apps on this which can identify who are at stress and who need a special support.
Okay, thank you very much once again. Applause to Professor Avinas for your very clear explanations and for your very broad
Thank you,
expertise
Titi.
that you bring to
Thank you,
us.
Titi, so much.
Don't be surprised if later a lot of Indonesians will contact you
Sure,
and
sure. No
watch your
problem. No
YouTube
problem.
channel.
No problem.
Okay,
Thank you so much.
thank you once again, Professor. In the rest of time, we will proceed to the next sessions. Can you, Diva, present Professor Ova CV, Professor Dr. Ova Emilia, Master of Medical Education, Specialist OBG, Consultant PhD. She will talk about the responses of medical and health professional education institutions for future use of medical mixed reality. So she will elaborate further what Professor Avinas already talked. One of the topic is about virtual reality, mixed reality, etc. She's currently serving as a director of Universitas Gadjah Mada. She completed her PhD in medical education from the University of New South Wales, Australia. Also, she has lots of work experience in medical education as a coordinator medical education innovation module, as assistant vice dean, chair curriculum development team, also as a vice dean for academic affairs, dean of faculty of medicine, and now as a rector. So without further ado, I would like to ask to invite respectfully Professor Ova Emilia to present your presentations. The floor is yours.
Hi, cheers from Yogyakarta, from Universitas Gadjah Mada, Indonesia. And thank you for inviting us to share the response of medical and health profession education institution for future use of medical mixed reality. Let me share our presentation. So, ladies and gentlemen, in these presentations, I would like to cover several points. First is about what is the global shift and urgency of mixed reality in health profession education, and what is the evidence and pedagogical foundations of medical mixed reality, and how the institutional prepare for this kind of progress, and also the governance ethics, and also research imperatives, and also future orientation of the mixed reality. We already know that simulation has become widely accepted as a valuable tool in medical education, and is increasingly used in all medical specialties to help bridge the gap between theory and also clinical applications of knowledge, skills, and attitudes. Advantages of simulation, like providing standardized and controllable exposure to clinical scenarios in which students can learn. Students also can make mistakes and try different approaches to the same scenario in repeated trials. And the format of immersive technologies, we know about virtual reality, mixed reality, and also augmented reality. So it challenges for education today. Like, for example, the complexity of healthcare, where knowledge is developing and also the regulation, and we all also know how the DC nowadays is become more and more complex. And also the concern of patient safety, like for ethics and also legal aspect in healthcare. And more ambulatory than inpatient, in which it also reduces the exposure for the students. We also face digital native learners, which create different challenges. And looking at those situations, no other choice for institutions to be prepared. At least there are 5 reasons. One, like literature shows that virtual reality improves learning outcomes compared to traditional methods. And secondly, it becomes a global competitiveness that can attract more versatile mode of learning. The third reason is changing of workforce into more digital native. And the fourth reason is more project and initiation for integrating AI and digital health. And of course, for the educator and educational institution is the accreditation now gives special weight for innovation in health education or in medical education. I think this challenge is worldwide. So what we mean with medical mixed reality, it actually integrates the digital holographic content into real clinical space for interactive learning. So in mixed reality, the digital and real world is integrated. And what is the difference between mixed reality, augmented reality, and virtual reality? Let me explain it in a more simple way. So augmented reality is the technology that overlays digital information, such as images, text, or 3D model onto the real world. So the main characteristic is it enhances, not replace, the physical environment, and very useful for guidance cues, labels, checklists, and simple overlay instruction. While for the virtual reality is usually fully immersive environment that completely replace the user's real-world sensory experience with a simulated one. So here, the user use the, you call it the head-mounted display, and cannot see the while they immerse. And what is the key characteristics? It is, of course, fully digital world and block perceptions of the physical surrounding environment, and interactions happens inside virtual space, and commonly used for simulation training, procedural rehearsal, and also immersive anatomy. Here the picture is for training the hemorrhage in postpartum hemorrhage. And how about the mixed reality? Mixed reality combines digital and physical world such that the virtual objects become specially anchored, persistent, and interactive with the real environment. You can see in the picture while they are doing the surgery, and they also can see the virtual objects to mimicking what we have to do next. The mixed reality also allows the users to see and interact with both physical and digital objects simultaneously and contextually. So there are several advantages. So it merged between the two words. The digital object will interact with the real world, and there are lots of greater contextual awareness than the augmented reality. So what is the literature showed? That actually AR and MR enhances clinical skills compared to traditional models. Exercise spatial understanding, like when you train, for example, laparoscopy, so for training skill, also the rehearsal of the skills, and also facilitate engagement to the real world, but still with the measurable and controllable outcomes. And of course, we need for vigorous research in this MR and also AR, so it can be developed further. Several theories supporting the MR, like MR works when grounded in the learning theory. So like the experiential learning that assert that knowledge acquisition is enhanced in environment where the learner can explore, experience, and assimilate new information in the context of what they already know. So in this case, MR has the unique advantage of giving users the freedom to explore knowledge and environment, which is not usually afforded in traditional method. And when we look at the collaborative learning, MR will enhance cooperation, idea exchange, and enhance knowledge acquisition. In MR, multiple learners can adopt avatars and interact with each other in virtual world. Collaborative learning in this fashion improves learner adaptability and critical thinking skills. Next, the MR also enables realistic representations of scenarios, and learners can be assigned different roles to solve a problem. So MR also enables the user to customize the scenario parameters and difficulty levels, as well as providing immediate feedback. MR also offers the perfect opportunity to overcome hurdles related to MOOCs. So we already know that the weakness of MOOCs is like poor interactivity, poor immersion, and also low participation level. And the MR can overcome this. So MR will enable constructivist principles to be implemented within the realm of connectivism. How do MR support the competency-based medical education? So MR actually enables students or learners have safe progression along the Miller pyramids. When you know from the lower, so students will knows how, shows how, and does. So here the MR is very good in shows how and for preparing for does in a safety manner. And also MR will be very helpful in skill rehearsal before patient exposure. In terms of interprofessional education, so immersive simulations also allows collaborative clinical reasoning across profession. They can share virtual emergency scenarios, also the team communication and crisis resource management. The question is, what should be prepared by the institution? So the issue is not, can we buy it, but are we institutionally ready? So I think it needs a systemic approach. So first, of course, is the vision and the leadership. So there should be like leadership that determines sustainability, like, for example, the strategic roadmap, budget allocation, and also digital transformation policy that should be set up in the high level. Yeah. And then there should be integrations of the curriculum. So MR must be embedded, not isolated. So it can be designed in all modules and all phases, and it should be designed in the more comprehensively. So it can develop the competency continuously throughout the education itself. While the preparation for the faculty is also very, very important, I think, and perhaps is the difficult part, because here we have not only I think most of the staff or the faculty are non-digital native. So we need to improve the digital literacy, and also need to train the instructional design in this MR world. And we have to really focus on who is going to be the champion. So this champion can be like a sample for the other faculties. And of course, we need feedback and also reflections, facilitation. The institution also should prepare the infrastructure and investment in software and content development, the support for IT, and also the replacement cycle, because you use many tools and also instruments in doing this, and also be prepared with the hardware as well. The other aspect is the governance and ethic, in which the immersive learning also create new ethical questions, like, for example, data privacy in terms of data of patient or the learner, and also the digital competencies progress, and also integration, AI integration. I think this is related with the number of data and type of data and scenarios. So not only bias into the extreme scenarios, but also to the general scenarios. And also psychological safety, which should be also put into concern for the learner especially. And in the university, I think this is the role of the university, where must also generate evidence, not only use it, implement it. So we need the RCTs and also the implementation research, and also learning analytics, cost effectiveness, also research on the impact on patient outcomes, which I think will strengthen the implementations of the MR in the institutions. And so for the future orientations, I think physical and digital learning spaces will merge. So we'll complement each other, and hybrid immersive classroom is more and more common. We have perhaps global collaborative rounds throughout the world, so we can learn cases from different countries, and also data-driven competency tracking, which is also very important to improve the patient safety. Yeah. And as a closing reflection, mixed reality is not about technology. It is about responsibility in preparing safer future clinician. Also, respecting the safety of the patient and, of course, the system, the health system itself. And the future of medical education will not be determined by devices, but by institutional courage to transform. Thank you for your attention.
Okay, thank you very much, Prof. Ova. In fact, she is now still flying. She is in the air. So if there are any questions, please you can put in the chat box, and we will compile the questions. When she has landed, we will ask her to answer the questions. Because we don't have question and answer for this session, we will go to the next sessions. Professor Simon Gibson, she's already here in the Zoom. Welcome, Professor Simon Gibson. She is from Monash, Australia. She is currently the Director of Education, School of Clinical Sciences, and Director, Monash Center for the Scholarships in Health Education, Faculty of Medicine, Nursing, and Health Sciences, Australia. She is the director, and also she is fellow of the Australian and New Zealand Association for Health Professional Educations, and also serving as editorial board of the journal, focusing on health profession education. Professor Simon is an advanced accredited practicing dietitian registered with Dietitian Australia and has over 20 years experience as clinical dietitian working across all major clinical areas, including intensive care, surgery, and endocrinology. Professor Simon was awarded a National Teaching Excellence Award in 2018 by the Australian Awards for University Teaching, and in 2017, the Vice Chancellor's Award for Teaching Excellence and the Dean's Award for Excellence in Education Quality of Teaching, demonstrating her commitment to student learning. She is also currently the Director of Master of Health Profession Educations and aims to support the future leaders in clinical and health educations. Without further ado, I respectfully invite Professor Simon to deliver the presentations. The floor is yours, Professor Simon.
Thank you very much, Prof. Titi. Yes, it is Salamat Pagi. And terima kasih for having me. And I'm going to share my screen now. Hold on. Where's the share screen? Okay, you can see that okay?
Yes.
All right, so yeah, I'm going to talk about assessment in competency-based education. And yeah, thank you for your kind introduction. And I would I wish to acknowledge the traditional owners of the land on which I am on, the Aboriginal people of the Kulin Nation. And today, being an educator now, no longer a dietitian, I have a few learning outcomes, and they are about exploring what is competency-based assessment and how it relates to work-based assessment, to discuss the challenges of competency-based assessment, reflect on the role of you as assessors and how that can influence assessment practices, and explore ways that assessment can drive optimal student-led approaches to learning. Now, I don't need to say who I am because Prof. Titi explained exactly who I am, so I will keep moving. So what is competency-based assessment? I'm not sure if you are familiar with Miller's pyramid, but that outlines where knowledge and doing are separate. So we have at the bottom knows, which is, so to assess knows, we're really looking at exams and tests and things like that. So that's about knowledge. Knows how is assessment such as case-based learning and case studies. Shows how is where we see competence, and that might be in OSCEs, simulated scenarios, and that sort of thing. And then at the very top, we have does, which is performance, and that is where students are in the real world doing real work under all kinds of conditions, and then we can see that they actually do what they're meant to do. So the sorts of competency-based assessment tasks, we have exams, which are not competency-based assessment, because I think the best way to look at it is, do I need to do this as my job as a health professional or as a doctor? And when we're working in a hospital or in a clinic, when we're with patients, we're not usually sitting in exams, nor writing essays or doing multiple choice questions. Sometimes lab reports, depending on the area, could be classified as a competency-based assessment task. But what we're looking at is like students performing authentic encounters. So workplace observations of students with patients, workplace observations of students in a team meeting, because that's another example of what students would be required to do once they graduate. Student consultations with simulated patients, or sometimes there can be written work that is assessed if it's authentic, such as an authentic project or grant proposal assignment. So the purpose of work-based assessment or competency assessment is the assessment of individuals in authentic settings, in that real life setting. The other thing about assessing in the real world or at work is you can assess a multitude of skills over a variety of cases and a variety of settings. So it's not always a simulated scenario with a particular type of patient. We get to see students in all kinds of areas. Work-based assessment gives the opportunity for multiple assessors to provide feedback and assessment. We want to check whether the student is ready to move to the next stage, and you can see there are other things on that slide, but I know that I only have 25 minutes, so I won't stay too long on this slide. So competency-based health professions education is inclusive of competency or practice standards that articulate the knowledge, skills, attitudes, and capabilities of a profession. The curriculum and assessment that supports achievement and measurements against these standards, and accreditation and policy procedures. So when we're assessing competency, we have to really think about, well, what is the competency that we're actually assessing? So competency-based education is centered around this framework, and it's defined by health needs and the health system. Like, we don't just come up with competencies like, oh, I think the student needs to be able to do this. Like, it's informed by the health needs and the health system, and those competencies are assessed, and those competencies inform what the curriculum's going to look like. So when we're thinking about competency and we're thinking about assessment, we really need to think carefully about what is the work we're preparing our graduates to do. And too often we just do what we did last year and what we did the year before and what happened to me when I was a student. But the competencies need to evolve. And I just caught the tail end of the previous speaker talking about digital, the impact of digital learning, I guess. And And that's going to change, that's going to influence competencies in the future. So we have to keep looking at what needs to change. And assessment is also going to be influenced by AI now as well. So the purpose of competency-based assessment is assessment for learning. Now, when I was a student, I went to university and most of my assessment was in end of year or end of semester exams. And I got no feedback on my exams. I just was given a test, I'd write some stuff, and then I found out whether I got 50%, 100% or whatever. And that was assessment of learning, but it wasn't assessment for learning. Now, best practice assessment means that what we assess for learning to help the student develop their learning. So the basic principle of quality assessment is we have a curriculum, we have teaching and learning, and then we have assessment that aligns with that. And that's what a good curriculum will look like. So that's ideal, but in reality, this is often what happens. So we might have a lot of, we might have a curriculum, we might have a lot of teaching, but no assessment at all. Or even the worst case, as you can see for example D, where we assess students, but we haven't told them what we're assessing them on and we haven't taught them how to do it. And those kinds of things are things like professional behaviour and the culture of the workplace and what is expected. Okay, so we also have to think about, when we're thinking about assessment, what level are we assessing at? And what I have often seen with students going out for placement is they're getting assessed as though they are competent when they've only just entered the hospital environment. So they are in fact novices. So we need to be very mindful of what stage they're at and what our expectations are when it comes to assessment. So novice learners rely on rules, they consider everything, and they don't know what they don't know. And as we move up the continuum, experts, they don't really have to follow rules so much because they rely on intuition and patterns. They're able to focus and they have a metacognitive ability. And this is just another diagram of the linear, it's not really linear, it goes up and down from novice to expert. Excuse me. Okay, so we have formative and summative assessment. Formative assessment occurs during the learning process and it's able to be reflexive according to how the student's going. Sorry, excuse me. And it gives opportunities for students to implement feedback. Summative assessment usually occurs at the end of a learning process. It provides that final evaluation of knowledge, and it's usually high stakes, which means that the student may fail the year, they may fail the subject, or they may fail their whole degree if they fail that test. Assessment for learning is what we really want to aim for. So we're assessing and students are learning from that assessment. To have assessment for learning, it means that we have to have regular formative feedback to assist the learner to get to that final assessment. The feedback on performance should foster the necessary competencies, and the quality and timing of feedback is important. So if you see a student and they're doing poorly and you don't give them feedback for 3 weeks, then that's not really fair on the student. It needs to be done as soon as possible, so then they have an opportunity to improve. So we also have to reflect on who we are as assessors. And I'm sure that those of you who have been involved in the assessment of students will find that there can be disagreements or different viewpoints on where they see a student on the learning continuum. So how do you know that your observation is correct and your colleagues is not correct? And this also includes the student. Like, what does the student think of their own performance? So we need to know who we are as assessors and where we're coming from. And does subjective mean unfair? And so I really recommend you read this paper by Brian Hodges, who talks about the value of subjectivity. The better I know a student, the better I can assess, as opposed to that objective measure. So that's just something to think about. In 25 minutes, we don't have a lot of time to go into that whole philosophy, but I do really encourage people to think of who they are as assessors, because we have because we're human, some of us will mark more harshly and some of us are more easy markers, and sometimes it depends on the area that we're in, the level of experience we've got, and all these other factors. And this quote from the paper: while there are many advantages to identifying individual domains of competence, to place more and more reliance on measurements of smaller and smaller dimensions is to risk losing the art of judging character. So sometimes with assessment, we can focus on a very narrow parameter of student performance without looking at the student as a whole. So I really want to focus, like with validity and reliability. I'm not sure how much you have learned about validity and reliability in assessment, but validity basically relates to the authenticity of the assessment activity. So you can have a reliable assessment, but it might not really reflect the work that the graduate needs to do. So the authenticity of the assessment activity, the effectiveness of formative feedback, multidimensional perspectives and student supports. For it to be reliable, on the other hand, we want clarity of goals, multiple assessors, not just one person, and multiple techniques. And going back to who am I as an assessor, so we all have variations in how we assess because we're not robots. Some of the supervisor factors in assessment, we all have a different propensity to trust. Some of us are very trusting people and some of us are more skeptical. Oh, what was that?
Okay, no worry, just
someone's microphone. Okay, thank you. There's the perceived risks of trust. So if I'm observing a student taking a medical history, that's kind of low risk. So I might be quite trusting while they're doing that. But if I'm assessing a student doing laparoscopy surgery, then I might have a much lower level of trust because the consequences of them doing it wrong are much higher. So you can see that there's all of these factors about the supervisor, about the trainee, about the task itself, and about the context that all influence how we trust our student and how we're going to assess them. So there's a thing called programmatic assessment, and programmatic assessment is becoming more and more popular in health professions education. And even if your program doesn't use programmatic assessment, I encourage you to adopt some of its principles because this is what it is for assessment for learning. So what I've got here is a picture, and you can all have a look to see what you see in that picture. And usually when I'm doing this presentation in a live audience, people see tomato, onion, and lettuce. So just say that's a student and you see tomato, onion, lettuce. Okay, that's my student. So when I assess them, I see tomato, onion, and lettuce, which I extrapolate to mean that's what my student is. Lots of tomato, lots of onion, and a little bit of lettuce. But what this really is a hamburger. But because I only looked at it from my own view using a single assessment instrument, I couldn't tell what the whole student looked like. So this is what a whole student might look like if we are able to look at it from many, many angles. And so this is where the basis of programmatic assessment sort of helps. So the first principle is having multiple assessors with training and appropriate skills and personal attributes. And the validity of non-standardized assessment resides in the users and not so much in the instruments. So there's a quote from Van der Vleuten and colleagues saying, "Sharpen the assessor, not the tool." Medical education in the past has spent a lot of time making these psychometric tools. How do we have a valid and reliable standardized tool that anybody can pick up and use and assess their student? But the research shows that we will all, even though we're using this standardized, reliable, valid tool, we will all still come up with different answers. So what we need to do is train the assessors. Not everyone is good at assessment, by the way. Some people can be quite unkind in assessment. So how do we get the right personalities to be involved in assessment too? Because we want assessment to be for learning. And if our assessment style is punitive and makes the student feel small and lose confidence with no useful feedback, then all we're doing is shutting students out of the system. So progress decisions are based on multiple assessment data points and moments. So I know that in Australia, and also when I was a student, some progress decisions of whether a student goes from stage 1 to stage 2 are based on one single assessment. They might have had 100 really good assessments up until that point, and then they fail the summative assessment at the end. But what we really need to do is look at those multiple data points and moments where we've seen the student perform to make that whole picture, remember the whole hamburger, so we know what it looks like. We also want to use multiple methods over time that facilitate, using tools that facilitate student learning. Any single data assessment point is flawed. Whenever we just see one encounter, anything can go wrong in one encounter. We need to see a lot of encounters. So decisions are made on accumulated evidence, triangulated, and where strengths counter weaknesses. So not only using OSCEs, for example, using mini CEXs. I presume that you use mini CEXs as part of your assessment. If not, no problem. But making sure that you're looking at different things to be able to get that big picture view of your student. And as I said before, the assessment has to include authentic encounters. So is what you're assessing the student to do, is it authentic, and is that something they're going to do as a graduate? And the stakes, when I say the stakes, I mean having an assessment task worth 80% is kind of, well, at Monash University, we are no longer allowed to have 80% for an assessment task. The largest assessment task can be 50%, but we're actually encouraged to have nothing more than 40%. So we have multiple data points to inform our final assessment decision. An assessment is considered part of a continuum. So this graph here indicates that students don't progress in a straight line. They go up and down towards going up. So even after 2 weeks, you might find that they are stagnating or their performance has dropped, but that doesn't mean they're not capable of improving in the future. And feedback is probably one of the most important parts of competency-based assessment. Feedback is what allows students to view assessment as learning. So every assessment task needs to have built-in effective feedback. The assessment needs to feed forward to the student, to the other assessors, and to the curriculum. So does your assessment, does that involve your colleagues, the other people who are going to be assessing that student, so you can all make a collective decision? And the assessment must be timely. As I said, if you have a student on placement for 3 months and the only assessment is at the end of those 3 months, then it's unfair on the student because they don't get that timely feedback and assessment in order to drive their learning. The programmatic principle of clearly defined performance criteria or standards, they're evident in each part of the program. And everyone has a shared understanding of what student performance needs to look like. So what I often see is the university academics have a particular view of what competency looks like. The student has a particular view, and then the supervisor in the hospital or in the clinic has a view. What we need to make sure is that everybody has the same picture of what competency looks like. And that has to be very clearly defined. And the other thing about programmatic assessment is enabling student agency and accountability. So the student is part of the assessment. So they're not getting assessed at, they're part of it. So that includes learning meetings and finding out how does the student think they're going. And it needs to be recurring and student-led. So this is something that is a work in progress for us here in Australia, because it changes the whole dynamic of a student-supervisor relationship where the student actually leads the assessment. And so that's sort of where we're in the middle of here in Australia. And I think I've spoken for over 25 minutes now. So hopefully...
It's okay, Professor Simon. We still have 5 minutes because the previous presenter, there is no question and answer. Thank you.
Okay, well, I don't have very much more to say because I really would like to, I prefer to have discussion rather than me just talking all the time. But just to revisit the learning objectives, we explored competency-based assessment and its relationship and purpose in work-based assessment. We didn't really get into the challenges, but I hope our question and answer time we can talk about the challenges. We had a bit of a think about how we as assessors may influence assessment practice. And we also touched on how assessment can drive optimum student-led approaches to learning. I have lots of references. I have shared the PowerPoint with Evie and Prof. Titi. So there's references throughout the PowerPoint and there's those references there. And yes, I would love to hear your questions.
Okay, thanks a lot, Professor Simon, for the very insightful and opening our minds about the assessments in competence-based medical educations. We have several questions. First from Dr. Gadjah. Thank you very much, Prof. Simon, Prof. Titi, and all listening participants. My name is Gadjah from Indonesia. With your kind permissions, I would like to address my question to Professor Simon Gibson. What strategies can be implemented to train multiple assessors to minimize subjectivity and enhance fairness in work-based assessment across diverse clinical contexts?
Okay. Thank you. Terima kasih for that question. I only know 2 words in Indonesian, by the way, and terima kasih is one of them. Okay, so I think the first thing is we need to look at the minimizing subjectivity. Because we are human, we are subjective. And I think the danger lies in pretending or thinking that we're being objective when it is impossible. The best way to address subjectivity is to make sure that we talk together. We have conversations about student progress, and I think it's owning our subjectivity. So if I have a student and I believe they're performing poorly, then I share that with my colleagues and the other assessors, and I give clear examples of why. And if that student reminds me of a problematic student that I had 2 years ago, then I say that. I say, hey, I just want everyone to know that this student is very similar to that one a couple of years ago who caused me a lot of problems. So I'm not sure I can be objective, or that's my subjectivity. And I want that to everybody to see that. But to train multiple assessors means that we have to all get together and we have to look at the competencies and look at the assessment tasks and talk about what it means, like what does that picture look like to each of us. The other thing is having workshops. So I'm not sure if you're all from different universities, but or different medical programs, but having assessment workshops where people get a chance to learn about the assessment tools, to learn more about assessment, to learn about how to provide good feedback, to learn how to encourage your students to self-evaluate as well. Lots of workshops. The thing about this is it is time consuming and it is harder than just getting a list and ticking off competencies. Does that answer your question?
Okay, thank you, Prof. Simon. The next question is from Dr. Siti Hadijah. Thank you, Prof. Gibson. I would like to ask about common standard or guidelines to develop competencies, as future competency needs are always changing.
Okay. These are very insightful, hard questions. You're asking the hard questions, which is excellent because it means that you have a deep understanding of competency-based education. So most of the time when we're developing competencies, where we review the ones that we've already got to see if they are still fit for purpose. And it depends on the field. I would say that the journal Medical Education has some good tips and guidelines. I can't think of the paper right now, but I certainly find it after this and I can email Prof. Titi and let her know. But you're quite right. Future competency needs are always changing and we do need to revisit them. So most programs will have a curriculum review process, and there'll be a panel of people who look at the standards and competencies. I think on that panel, what you need to have is stakeholders from all areas that are affected, that are involved in the program. So that includes students, graduates, university or academic lecturers, supervisors who are in the workplace, patients or patient advocates. So everybody has a say in what those competencies are, and then you go on about how they might be assessed. But it does need to be here at Monash University. We review every curricula. I think it's every 4 or 5 years. So it needs to be done on a regular basis. Yeah.
Okay, thank you. Are there any questions, Diva?
Yes, Prof, from Dr. Siti Khadijah Rahmania.
Yeah, we already. Oh, from myself. I'm asking about could you elaborate on the importance of looking at the student as a whole rather than just focusing on one dimension of competency or micro skill, such as in OSCE. And also, now programmatic assessment is also a global trend for the assessment in competent base. But how will be the transcript? Because we used to have transcript based on subjects or courses or modules with A or numeric. So what will be the transcripts for programmatic assessment? Thank you.
I'm not sure what you mean by the transcript.
The report of the students' results.
Oh, okay,
Yeah.
okay. Well, what is happening in many medical schools is they are having pass grade only. I know, I'm pretty sure that happens in Singapore at Monash University in the early years, they have pass grade only. So the focus moves away from the number at the end, 60, 70% distinction, high distinction, whatever, and it moves towards the qualitative feedback about how the student is going. So it's a real mind shift in how we assess, because for decades, maybe I can't even think, from the history of medical education, we have relied on numbers and psychometric assessment. And moving that to that qualitative feedback about, I mean, still you need to have a bar. I know, like it's like we can't remove numbers completely. Like there needs to be a bar that needs to be passed, but that needs to be described rather than just a single number. And to get so what we're in one of the programs in nutrition and dietetics at Monash, we now have a learning panel, like a progress panel. So the student will have performed multiple assessments across, so they might have done an OSCE, they might have done an essay, they've done numerous patient encounters of, providing counselling, prescribing nasogastric feeds or whatever. They've done all of that. They might have done some well, some not well, and all the assessors that were involved in all of those things come together as a group and discuss the student. And so then we can see the whole hamburger of the student. So as we know, so the thing is, when we're assessing the micro skills, any of us can probably suture once we're taught how to. Yes, that was a good suture. Yes, you get 100% for that. And then on another isolated occasion, I can deliver bad news to the patient. And then on another isolated occasion, I might be able to do, all of the other things. But can I do it all together as in a busy workplace? And so for that to happen, the student needs to be assessed in their real life environment, and one person can't be following them around the whole time, nor should they. So we need multiple people coming together and discussing what they find. And when I've been involved on those learning panels, sometimes I've been like, what, I don't think that student is going very well. This is what I saw. And then I hear the other people. Sometimes they're like, yes, I saw that too. And then we go, yeah, they probably aren't ready to progress, so let's not do that. Or all the others might disagree with me and they might say, no, that student was great. They were really good when they do all of those things. And so then I listen. I'm like, okay, well, what was it about this assessment that they did poorly? And so then we come up with a collective decision. In ideal programmatic assessment, the student is also part of that conversation. But that requires more training of assessors, training of students, and that might be a little bit down the line for many medical programs.
Okay, thank you. Next question from Dr. Muhammad Idam. I would like to express my sincere appreciation to Professor Simon Gibson for inspiring presentations. Medical schools currently possess a vast amount of assessment data that could be analyzed to provide deeper feedback. In your opinion, how can institutions best leverage this data to support student reflection and foster self-regulated learning? How can we transform these analytics into a meaningful compass for students to manage their own learning journey?
Oh, thank you. That's a beautiful question. And I think it might, like, from an operational point of view, it might depend on your systems and organization. But what I do say is that the student should have access to all of that data. Like, they are the student, it's their assessment, they should own the data. And for too long, students have been isolated from their assessment data. So how can institutions best leverage this? I guess it's advocating upwards and yeah, just making all of that assessment data visible. The thing is, if I'm providing assessment to a student, I always think that the student is going to read that, hear that, see that. So all of my assessment feedback needs to be done in a respectful and constructive way. And then if we can train assessors to do that, also knowing that everything they say, everything they write, there might be some private conversations you have to have about delicate matters, definitely. But the students need to see this. So then, as you said, they can have self-regulated learning. Because at the end of the day, when we graduate, apart from exams for traineeships and that sort of thing, we're on our own. We need to teach students how to reflect and have self-regulated learning. And they have to have access to the data themselves. Yes.
Thank you. The any questions?
Yes, there are 3 more questions.
Okay, from myself again. Okay, there are quite a number of questions. Thank you, Prof. Simon. Amazing presentation. My name is David, an MHP student from Gadjah Mada University. I would like to ask regarding the assessment of professionalism. Do you have any pointers on how could we deem a student is competent in terms of professionalism? As we know, professionalism is quite complex and abstract to define. Thank you.
Yes, thank you. You are absolutely right. Professionalism is abstract and hard to define, but what you need to do is define it. Do your best to define it. Because if we can't have words or any way of telling our students what professionalism looks like, then we can't teach it. So a colleague of mine, she did her whole PhD on professionalism and defining professionalism in dietetics, because everyone will have, because professionalism is dependent on culture of your organization, culture of your country. Like, I am sure that there are things that Australian students, if they were in Indonesia, if they did some of the things that they did in Australia and they did it in Indonesia, it would be deemed unprofessional, and potentially vice versa. Because professionalism is intricately related with culture. That's culture of people, culture of organizations, culture of professions. Even what is professional in surgery might be different in general practice. So you need to think about what that is and write it down, have a list. And it might just be things about being punctual, like start with the easy stuff, being punctual, being dressed appropriately, and maybe think of some of the things that you see where students are not professional in your experience, then you write those down. Because if students don't, none of us go out deliberately to be unprofessional. You know, I when I was a student, I didn't go to my placement going, I'm going to be unprofessional today. How might I do it? You know, we're unprofessional because we don't know. It's the hidden curriculum. So yeah, you need to talk about it. You need to talk about it with students. You need to talk about it with the greater organization and write some things down. There are a number of really good papers on defining professionalism. I can send you the one that my colleague wrote. It's in dietetics, but the principles are the same. So I'm happy to share that with you. But I'm really glad that you're asking that question, because it is something that has been put in the too hard basket for too long, and students suffer. Because the other thing about it, if a student is being unprofessional, it's hard to have a conversation with them about it too, because it's personal. It's not you did, you did this medical procedure wrong. It is usually something about their person that you're having to have a conversation about. So learning to be able to have those conversations in a respectful, supportive manner is good. But the first thing is we need to define it so everyone has a shared expectation and everyone knows what the standard is.
What about the assessment of professionalism?
Okay, so what we do is we have the standards and we share that with the students. And then we don't say that someone is being unprofessional, we say that they have had a professionalism lapse. And so that might be they're consistently late, for example. I'm not sure what examples are common to you. And so first we have a conversation. And, we might have the list of all the professional behaviours that we expect. And I'd say to the student, okay, so there's a few things on this list that I have noticed you seem to not be doing. And one of them is lateness. Have a read of the list and you tell me what's going on. And ask them, why are you late all the time? And usually what I find out when I ask the question of being curious is I have to catch public transport and it takes me 2 hours to get here, or my mother is really sick and I have to look after my brothers and sisters, or, there's usually some personal reason behind it, but not always. And it's so what they have is you have a number of conversations which are always documented, and you might have them with more than one person. If at the end of the day they remain unchanged by your conversations, then they might have to fail. But it's not graded. It's not like I get an A for professionalism and a high distinction or whatever. It's about conversations, but knowing at the end point, if someone's not professional, they do not progress, because instead of it being, because professional skills are often called soft skills, but we don't call it that, because they are actually usually the hardest skills. They're the hardest to learn and they're the hardest to train. Does that help?
Okay, thank you. Another question from Dr. Sinta Wardani. My name is Sinta. I would like to ask about the possibility of entrustable professional activity to becoming programmatic assessment tools in workplace-based assessment for residents.
Yes. So here in Australia, entrustable professional activities are becoming quite standard for medical traineeships. I think it's a whole other presentation, EPAs. I do think it's a really good way forward. But people, again, need to be trained on what EPAs are, because they are looking at they're kind of portions of a whole part of work. And the danger is in busy clinical environments where people don't have time, they will turn entrustable professional activities into tick boxes again. Like, once again, it's about understanding the philosophy and purpose of assessment and having good assessors. But I think EPAs are a really good way forward, as long as there are those parameters in place.
Thank you. Next question is from Dr. Elisa. Thank you very much, Professor Gisem, for your insightful presentations. In Bate et al.'s paper, the author described a key tension. Although programmatic assessment aims to enhance meaningful learning and reduce stress, students felt over-assessed when continuous assessment were added without reducing the weight of high-stake exams. Because major exams still carried significant weight, students continued to prioritize them. As a result, continuous assessment were often perceived not as learning opportunities, but as additional threats competing with time needed to study what they considered real medical knowledge. From your perspective, what practical strategies can institutions use to genuinely shift the paradigm from assessment of learning to assessment for learning in contexts where grade culture and high-stake exams remain dominant?
Okay, thank you. And I don't think that it is possible to have assessment of learning when you have high stakes, high weight end of semester exams. I don't think you can do both at the same time. What I think that what you'll have to do is to genuinely shift that paradigm is to remove those end of semester high stakes exams and show it's not going to be easy. And maybe you just make little changes at a time. So from changing it from 80% to 70%, but also looking at the literature, like, what are high stakes exams assessing? They're not really assessing they do a good enough job. Let's get, like, they've got us this far in medical education. But look, even without those end of program high stakes exams, that we're still learning to find the balance of programmatic assessment and not being over assessed, because it's kind of like the pendulum swings, like it's gone, it was very heavy. All they needed to do was study for the end of year exam, and that was it. And then it went to, in some programs, lots and lots and lots of little assessments, no end of year exam. But even with that, students were like, I can't even move without being assessed. Like, I feel like I'm being assessed at every moment. So how do we, and I don't have the answer to this, but this is something we're just going to have to keep trying and working out and moving and getting evaluation and feedback ourselves on our curriculum design. I'm not sure what the sweet point is of how many assessments they have along the way, but I do think that we need to advocate for removing those high stakes exams at the very end and getting trust in those smaller assessments that happen during the semester, because it's just a concept, really, of that this high stakes exam is the be all and end all. And, we know that many doctors out there are incompetent despite having passed those exams, although most are competent. But this is a trial and error thing.
Right. So this is important. You said that it is not possible to merge programmatic assessment and high stake exam together. So we need to gradually move to programmatic assessment and remove the grade culture and high stake exams.
Yeah. And look, I think it will change, but it just, the people in power, and I think, like Indonesia, your culture, it's going to be harder to shift, but it's still possible.
Okay.
And I think the other thing about it, though, is maybe for those have less assessment make it very clear to the students, this is formative assessment, and that's a chance for students to build their confidence and still get feedback. But yeah, how do we remove that? Yeah, it's a good topic.
Right. Thank you. Is there any question, Diva?
That's all, Prof.
Okay. Thank you very much. Once again, Professor Simon. We hope you don't mind if any of the participants would like to connect you later on to know further about programmatic assessment. Okay, once again, thank you very much. Now we would like, okay, close to Professor Simon. Now we move to next presentations from Professor Ham Peters. I think Professor Ham is already here. Professor Ham now we'll talk about the experience in Europe of implementing competent-based medical education. Professor Ham Peters is currently the president of Association of Medical Schools in Europe, and he is a professor in medical education and nephrology at Charité Universitas Medicine Berlin, Germany. And he has extensive experience as medical educators. Also, he is involved in many associations in Europe as executive committee, also as treasurer. And Professor Peters has been actively involved in education reform initiatives for 2 decades, both as teacher and curriculum developer. In 2010, he was assigned to be the director of the project team for the new modular curriculum of medicine, and 2 years later to become head of the Dieter Sefner Center for Medical Education, both at the charity. The new modular curriculum of medicine is a 6 years program that represents a fully modular, integrated, competence-based, student-centered, and patient-based curriculum in undergraduate medical education. And the Dieter sorry for spelling center consists of a multidisciplinary team with curricular experts in the fields of curricular development, assessment, problem-based learning, communication skills, e-learning, and scientific working. With regard to medical education, Professor Peters also have research interests in competent-based education and employment of interested professional activities. Without further ado, I respectfully invite Professor Ham to deliver the presentation. The floor is yours.
Thank you very much. Good morning from Berlin, or good afternoon. Can you hear me well?
Yes, Professor
Yes,
Ham. Yes,
wonderful.
yeah.
Dear colleagues, thank you very much. Thank you very much for the very kind invitation. And Professor Titi, it's always a pleasure to work with you. And of course, when I
Thank you.
received your request, there was no other choice than to say, yes, I will do it. Although, for me, it's in the middle of the night. Not really. It's 6 o'clock in Berlin in the morning. I'm just up, have my tea here. I'm good. And for those of you are following this, please understand, I like always to be a little bit provocative on what we do and how we do it. And yeah.
Wow, keren. Sorry. Can you mute the?
Okay.
Okay,
Go ahead.
sorry. Okay, go
No
ahead.
problem at all. This is active participation. I like to be a little bit provocative. And when Professor Titi asked me to talk about competency-based medical education in Europe, for me, this was a chance to reflect on where we are actually and where we may think we are. Therefore, see this a little bit as provocation from somebody from Europe on Europe itself. So I will now share my presentation and keep fingers crossed that it works. Looks good. Looks good.
Yes, it's clear.
So, okay. As you can see, I'm coming from a big city, the White Tower, the Ivory Tower, that's the tower of the Charité, where most of the hospital beds are, and that's a look of our city. And I am here now presenting competency-based medical education and health profession education experiences from Europe. And Titi, if something has to be changed or you cannot hear me, please say something because I just see my screen and not the people. Okay. Let's have a look. Okay, the agenda. I will start a bit about the context where I will connect Europe and Southeast Asia, and I will connect the association I'm the president of. Then I go to the roots of CBME, the competency-based medical education, and the CBH, health professional education. I use these in one way or the other. Then I go on to the stages where we had integration and outcome-based curriculum. Then from that, I move to CBME and CBM-HPE to EPAs. That's the outline where I will go. Okay. Let me start. I'm the president of the Association of Medicals in Europe. Therefore, many people may think, oh, I have an idea what Europe is. Europe is much more complicated by what you call Europe. And here I will refer to the World Health Organization or definition of Europe, because that's the perspective Professor Titi and I have, because we are representing these regions. And I'm saying this because it is a little bit surprise if you look at that. This is a big green field. This is not the European Union. This is not the geographical continent of Europe. It is a region defined by WHO, and it goes from Greenland over to Russia to Vladivostok. And what you can see here, there's also the Southeast Asian region. And here, Professor Titi is the president of the association. And here in Europe, I'm from Berlin. I am the president of the Association of Medical Schools in Europe. Just to give you an idea what in this talk Europe means. Okay, good. Let's move on. What is AMSI doing? We are an association of medical schools, not of medical students, not of medical professionals, of medical schools. And we have members from 28 countries, from 75 medical schools. And our mission is to provide a forum that these medical schools can share experiences in the field of education, but as well as in research and management. Therefore, we are broader than education. Good. Now, let's have a look at these two regions, because I think it's important to stress the context is different, but the problems we have and we have to deal with, they are similar. Good. What is it? When I look at our societies and patients, we have an aging population. We have a shift from acute to chronic disease. We have consequences of the climate change, and we have disruptions from pandemics, disasters, or wars. And we have an increasing shortage in healthcare workforce we have to deal with. This is for the patient and society. If we then look for medical schools, our task we have, what we share, we are educating our future healthcare workforce. This is physicians, nurses, midwiferys. And we are preparing for an uncertain future practice. This is something challenges because we just don't train for being fit for practice. We have also to train fit for future practice. That's challenging because we have these disruptions will come in, new diseases, new diagnostic and therapeutic approaches. And not especially now, the emergence of artificial intelligence, which is infiltrating and changing almost everything we do, what we think. We have to see how it works out and where it's really helpful. And what we are all facing is we have limited financial resources, and they will be even more limited. And there is a greater need for collaboration within healthcare teams. And for us especially who are dealing with the training of our future healthcare workforce, those who are in the workplaces, and I refer here to physicians because I'm a physician, I'm a nephrologist, and I have been on service tonight. I got 2 phone calls in critical situations tonight. I'm a physician. There is limited time for the busy physicians to train the next generation because they are taking care of patients and for faculty development activities. Therefore, this is a different context, but similar problems. I hope you can connect to this. Next. When we talk about competency-based education, medical education, or health professional education, what do we mean by it? Yeah, I can say this is a challenge because whenever you go to physicians, they say, why is this so complicated? It is complicated, and that's part of it. Like professionalism, we heard before, it's complicated. But what do we mean by it? I've like this quote, which is also not an easy quote, but it captures it very well. It's coming from Jason Frank, Snell, and Tim Carter. And it says, CBME is described as a renewed, therefore this is not something completely new, outcome-focused approach, therefore it's about outcomes, that is organized around competencies, emphasizes accountability and curricular outcomes comes again, and de-emphasize time-based curricular design. These are the components: renewed, outcome-based, and organized around competencies. Okay, now let's see how we arrived at CBME around the world, and especially in North America and in Europe. Okay, when we look into the past, healthcare was very different. You see here one picture from if healthcare was provided at home or healthcare was provided in hospitals. On the right-hand side, you see a patient in a large room with many patients, and there's no doctor around. There are nurses taking care of the patients. This was also the case at the Charité where I'm working. Then, if you look nowadays, healthcare has changed very much. On the left-hand side, you see how many machines we have there, and what we all do with the patients, and that we are working in a team, and how this is really different. And on the right-hand side, you see the agent patient. You see how we have to work together to help our patients to be mobile and master their lives. This is a big change in healthcare. This mirrors the change in healthcare education. Healthcare education is mainly always a response to the changes in healthcare, to the needs in healthcare, although it's slow. On the left-hand side, you see a typical lecture presentation, and even the surgery was done in the lecture hall. And you see the gentlemen's and the black coats. White coats were not there yet in the black coats and the jackets, following this and learning. And they came from all over the place to see what some people can do in the surgery room and take it to the world. On the right-hand side, you see students where they are dissecting and learning anatomy. Okay, this learning has changed as well. You see on the left-hand side, a typical simulation area where you have this science. In Germany, it's called SEARAME, where you can do auscultation and some skills training. On the right-hand side, you see a typical situation where communication is trained. Therefore, these are the changes and the needs we had in the healthcare. That's where we are coming from. How did we get there? What has happened? Why and how did healthcare change in that way? What has happened? Let's have a look. I came from the roots and now I move over to key themes we have in there. And one key theme is integration and outcome-based curriculum. Let's have a look at that. Okay. When we do this, it's important that we understand that the way we do education, we are doing it in a curriculum. And you see on the left-hand side a picture from Berlin. This is Eliud Kipchoge, who ran 2017 here the Berlin Marathon, and he did a world record, therefore a little paid. And I chose this picture because curriculum is the Latin word for a race, a course of race. And those who are in these curricula, they know it is a run from one place to the other when there are certain stages you have to go for. The idea of curriculum came out in 1600, and it was used curriculum as a course of study, and it was introduced at that time, 1600, because it was linked to a desire to bring greater order to education. This means in former times there was no order in education. Okay, good. What is it? It refers to the totality of students' experience that occur in educational processes, or like one person, Ronald Harden, said, a curriculum must be more than a syllabus. It is the expression of educational philosophy, goals, content, and learning process of an institution. So this is curriculum. Now let's look how we arrived at CBME. Here are phases of curriculum and phases of reform. There is this very traditional curriculum area, and I refer here to medical education because this is most well documented and can be followed. And this is the area where from before the 1970s, and this was driven by Abraham Flexner, who separated the curriculum in a preclinical phase and a clinical phase and made it medical school, mostly university-based. The next phase was the integration and outcome phase, which was in the 80s and 90s. And here you see Ronald Harden, and I will talk about Ronald Harden more. And Nowadays, we are in the competency-based medical education phase. So now let's go to the second phase, integration and reform, and then move over to competency-based medical education. You know, Ronald Harden is in Europe and globally one of the key drivers of medical education change. He is the father of the OSCE. He is the father of the idea of doing integrated outcome-based curriculum. And he is from Scotland. And you see here our map from Europe, and I labeled red Scotland. And he is really a star on our firmament. But I will come back to this. I think if Ronald Harden is still living, and he's about 90, and he is really he is, for me, the most influential medical educator over the last 50 years, even much bigger than Flexner. Okay, let's think, let's see what he did regarding the curriculum. Here are his signatures. He was a big protagonist for integration, and for that he developed the SPICES model, a new curriculum outcome frame. And the SPICES model provides a framework for rethinking curriculum structure compared to the traditional one, from a teacher-centered to a student-centered, from an information-based to an outcome-based. What does it mean? In former times, on the right-hand side, the curricula were teacher-centered, subject-based, discipline-based, hospital-based, standard program, opportunistic. With the SPICE model, it was student-centered, problem-based, integrated, community-based. It provided electives, and it was a systematic approach. With this, he also developed or put forward the idea that the curriculum has to be integrated and follow a spiral form. What you see on the left-hand side, you see the different years, and from the clinical methods, ethic, and health promotion, it goes through different phases where they start with normal structure and function and behavior, go up normal structure and function and behavior, clinical practice, and then on the job learning. And he put forward the quote in Medical Teacher: "The spiral curriculum revisits topics over time with increasing levels of difficulty and sophistication, reflecting how people really learn." This is all well said. And even more, he said, good curriculum planning starts with the end in mind. What kind of graduates do you want to produce? This is outcome-based, and it's very important. And curriculum alignment ensures that the learning outcomes, teaching methods, and assignments are all pulling in the same direction. These are the signs of curricular integration. Okay. I asked the question, what has happened? I think Ronald Harden in the 80s and beginning of the 90s, he really pioneered this, and he transformed the way we are thinking about how we teach, assess, and think about medicine. It was a combination of theory and practice and innovation, and it favored an integrated outcome-based curriculum. And in addition to that, many people would say it shaped global standards and educational philosophy, and his influence endures across institutions and continents. Now, I would like to be a little bit provocative because I did a look at Europe. And here's Ron Harden, here's his star. And if you look at the papers and the journals, Medical Teacher, he is also the editor of Medical Teacher. There's Medical Education and Academic Medicine. There is a lot of publication about integration and outcome-based. It's full of it. And if you just read that, you get the idea. It's everywhere. Now, coming back to our map in Europe, you see on the left-hand side Scotland, this nice little area where he is coming from, and Ronald Harden was most influential. And I asked the question, where in Europe, on a national base, where do we really have implemented integrated curricula on a national base? integrated curriculum. And I'm saying this because I'm from Germany. In Germany, most schools follow a traditional way of curriculum where they have 2 years of preclinical, then 3 years of clinical, and 1 year for the final clerkship year. Therefore, I did a search for this one here. And if you really look where this is the main component at a national level for undergraduate medical education, you see this is all over United Kingdom. This is Iceland, this is Norway, this is Sweden, this is the Netherlands and Switzerland. And all other countries at the national level, they follow mainly a non-integrated curriculum, where the curriculum is divided in preclinical and clinical. Although, of course, they are at the lower level, at a local level, there are signs of integration, but that is really like Ronald Harden said, that's how we do it. There's really little implementation of that. Okay, this is now about outcome-based and integrating. Now let's move on to CBME and to EPAs. Okay, brief reminder. This is a renewed outcome-focused approach organized around competencies. And let's have a look where we are with that. When the approach to think about the training of healthcare professionals and getting away from just knowledge there, that in medicine this means that you are just a medical expert with medical knowledge. This was driven by North America, the US, and in particular in Canada, which developed this very nice little flower, which is called our Commemorate framework. This is, in theory, a very well taken approach, because if you look at daily practice, it's completely clear. You must be able to communicate. You must be able to collaborate. You must manage. You must be a health advocate. You must be a scholar and a professional, as we have heard before. And this is for our young colleagues coming in the field. Therefore, this is a big movement, and it's a big theoretical concept like professionalism, which makes it difficult for those who are in practice really to grasp it. But it is a big step ahead, and it much better reflects the idea that you are just a medical expert and somebody who has knowledge. That's good. Okay, and here you have the roles again: expert, collaborator, communicator, manager, health advocate, scholar, and professional. Okay, now let's have a look how this impacted on Europe. This idea, especially the Commemorate model, is also a star on our night firmament about health professional education. On the left-hand side, you see 2005 Europe. All blue, that's where we are coming from. There is no CBME in 2005, of course, because it has not been invented yet. And if you really look at the national level, for undergraduate medical education, I had to be selective, where this is really used as a national framework for undergraduate medical education, and this is published. This does not mean that some schools do it and they have, within their traditional way, they have some sort of emphasizing competencies. Now let's have a look how it looks 2026 in Europe. Implementation of CBME. Okay, it's the United Kingdom, it's the Netherlands, it's Switzerland, Spain is in there, and Turkey. But the rest, at the national level, they have no CBME framework which schools have to implement. That's where we are. Next one. One step I particularly like very much is the idea, how do we translate this into practice? And if we look at the competencies, and we had just heard the talk about the professionalism, being a professional, it's really difficult to translate competency-based education into practice, or that those who are in practice say that's something I can use, because the wording is unclear and the way it is presented is unclear, because clinicians, they think in the work they do. And the nicest quote I have from my colleagues is, okay, if I look at this, then it looks like Monday, I'm a medical expert. Tuesday, I'm a collaborator. Wednesday, I'm a communicator. Thursday, I'm a manager. Friday, I will be a health advocate. Yeah, and on Saturday I will be a scholar, do my scientific work, and on Sunday I'm a professional. I go to church. Yeah, and he said my work is not organized that way. I'm many of these roles I'm in parallel, and those who are doing this from an assessment point of view, they tried hard. They failed to really distinguish this rule in an assessment. Whenever you look for somebody, whether he is a communicator, you cannot disentangle this from being a medical expert. And therefore, this concept is very nice in theory, and it has really advanced it. But as all, and I'm saying this as a nephrologist, things are developing over time, and we want to get to the reality of the workground closer and closer. CBME gets closer to the workplace, but it's not really fully there yet. And with this, the idea was put forward by Professor Olle ten Cate from the Netherlands. Let's think about entrustable professional activities and use them to translate this theory of CBME into practice. And he observed how physicians and healthcare workers were working, and he identified that they have a common thing they do. They do not really explicitly using this, but what they do is they are using entrustable professional activities. What is it? The professional activities represent units of professional work. For example, tonight I'm on a night shift. It's a unit of work. And my young fellow in the hospital is doing a night shift. That's a unit of work. And we have entrusted our young fellow, our resident in the hospital, to do this unit of professional work. And they are very characteristics for the professions. They integrate, that's a very good thing, their relevant skills, attitudes, and knowledge, as well as the competency roles to carry out this task. And for those who are doing assessment and teaching, they are observable and measurable. That's good. And what's really around the world, these professionals' activities, that's what many healthcare systems do without thinking about this. They can be step by step be entrusted to trainees from direct supervision. I have to look at you to independent practice. And these are entrusted when the level of skills has reached, and this matches the task to be done. Okay, just another look at that. Here you have our healthcare trainees, and if you look for medical, take a patient's history, perform a liver biopsy, perform a ward round. You can see different competencies are going into these different tasks. And therefore, on the higher level, you have the task. On the lower higher level, you have the skills, the knowledge, skills, and attitude to perform the task. That's very helpful because it's very tangible. Okay, now you are used to this now. This is now 2005. Olle ten Cate, of course, he gets also a star in our firmament of medical education, and he has very well, and those people around EPAs, they have very well published in academic medicine, in medical education, and medical teacher. And if you look at these journals or go to the conferences, you would say there can be no doubt it's all over the world, and it's in particular in Europe, it's everywhere. Okay, what you see on the left-hand side, little red, the Netherlands. Next to Germany, a little country where Olle ten Cate is coming from Utrecht. And now I will have a look on the implementation of EPAs. And for this, I'm also again focusing on medical implementation. And I was looking for both, or either it is implemented in undergraduate education, or it is implemented in postgraduate education at a national level, and now this is the outcome. It is in the Netherlands, it is in Ireland, it is not in the United Kingdom, it's in Switzerland, and it is in Lithuania. But for all the other countries, there are no EPAs implemented at a national level. Okay, that's where we are. So let me have a final look where I'm coming from and where I am. I'm from Germany. It's very unusual to have an integrated curriculum. It's very unusual to do it outcome-based. It's very unusual to do CBME. It's very unusual to use EPAs. But we at the Charité, we are a little bit crazy city and a crazy university. We like to be in the forefront and to do new things. And what we have is our undergraduate health profession education programs, which means medical, nursing, and midwifery. We have integrated curricula. We have outcome-based design. We have a defined, written down, competency-based framework. And in all of these three programs, we use EPAs in the workplace, which we have defined by ourselves. So, and you see on the top the Aspire Award. That's a way to acknowledge excellence in medical education, and the Charité was acknowledged as star for the things we have done in this. But we are an exception. Okay. Now, I'm coming to the end and to the bottom line conclusion. For Europe, this is for Europe, and this is my personal reflection, where we are at around the topic competency-based medical and health profession education experiences from Europe. Okay, we have in medical education, we really have great thinkers, wonderful people. They all get a star. They produced very nice ideas, great stars. They are widely published, and this publishing leads to an idea that it's everywhere. But if we look at the reality on the ground, yet too little implementation in practice. So for the work I'm doing, I'm putting forward our challenge may not be generating more great ideas, it's translating them into day-to-day practice. Having said that, I say thank you very much for your attention. If you want to get in contact with me, here are my email addresses. And I'm now stop sharing the screen and coming back to you. And I'm happy to take any questions. And please give me or understand, I like to be a little bit provocative, but please have in mind it's about being provocative about my own context, the work I do, and to stimulate the things where we are and to stimulate the focus where we should work on in the future. Thank you.
Thank you very much, Professor Peters, for a very insightful presentation, as well as for being provocative. So it really it has made us realize, your closing statement that there are many great ideas about publications, but too little implementation. Okay, any questions, Tifa? Please. Are there any questions? Yeah, so the challenge is to translate from theory to practice. So what do you think are the reasons or the causes? A lot of people knows about, great ideas in innovations, in transforming or in reshaping the curriculum of medical educations. But why most medical schools are still implementing the traditional ways?
Yeah. I can say this from my perspective, and I can say this from my clinical practice. I'm a researcher and a clinician in the medical field, and what many people think, and that if they have a good idea for medical practice, for example, if the good idea, just having a good idea, this translates automatically into practice. And we all know this is not the case. Just a few examples from my clinical work. You know, in 2002 at the Charité, we started with a different mode of dialysis in the intensive care unit, where we used, instead of heparin, where we used citrate. And citrate is very safe for the patient. It does not lead to bleeding and all the other complications we have with heparin. A great idea, a great idea. But to put this into practice took us 15 years. What do I mean by this? First of all, we have to set up our own system. Next, we have to put it on the one ICU ward. And many people said, what are you doing? We want to use heparin. We want to, just the local people, the people we know. Then we needed, at the end, it was the nursing staff said, we like this citrate. And then we said, why do you like it? Because the machines are running and running and running. They run for 3 days. We do not have to change them all the time, because with heparin, they're always clotting and so on. And we had to do many steps to make this a really global innovation. And in addition to that, we had to team up with a big company who helped us to put this forward. There was no money. We had to say that we are not interested in money. We want to disseminate the idea. It took us 15 years. And now, after 15 years, it has become a worldwide standard to do this way. Started very small. Therefore, implementation is their own way of science. And if you look at the clinical research, many things they are now working on, they always say we have a translational problem. We have ideas, they are not translated into practice. And they put a lot of effort to putting in money and people into this translation. And we have too little translational effort. We have too little implementation science. And with this, our activities, they start and then die a few weeks or months later, or when we are not there. Therefore, we do too less about implementation science and about translational strategies.
Thank you.
And final thing, Titi,
Yeah.
and this is something everybody can learn.
Yeah.
And this is something we can teach.
Okay. Right. Are they okay? Some
Yes,
questions.
there are 2 more questions.
Okay, thank you. From Dr. Asri, thank you very much, Professor Peters. Based on Harden's integration model, would it be appropriate to teach physiology and pathology in parallel from the first year of undergraduate medical education? And what are the key pedagogical principles to ensure effective implementation? Thank you.
Thank you very much, Astrid, for asking this question. That's what we do at the Charité. Our students, in the first weeks, they see the first patients. The first patient, and then they have patients along always. And we teach them physiology and pathology from the beginning. Of course, the simple things, the easy things, and what our professors of physiology and pathology say. If we do this from the beginning, if we connect this to the seeing patients, then the students learn it much better. Because it is different if you learn physiology today and 2 years later you see the patient where this physiology or pathophysiology takes place. And what are the key pedagogical principles to ensure effective implementation? This is a holy question. Because how do we make sure that the students learn what we want them to learn? For me, the major shift is to give this into the hands of our students themselves, because they learn what we are providing something, but what they learn at the end, there is a high impact on what they decide. And they often look at practice. Of course, you can put in a very big assessment system, which may fit or not fit, and the students will learn what they need for the assessment. But this is just for the assessment. They're also learning for life. Therefore, try to match your assessments close to what students and later need in the workplace. And always in your decisions, have students with you deciding on this. this give them an active role, not just having a voice. Give them an active role to develop these things, and then you get closer. You will get very close because you cannot look into the brains of these students.
Okay, thank
That's
you.
yeah.
Now we move to the next questions from Dr. Christopher David Kurniawan. Thank you, Professor Ham Peters. Very insightful presentation. I was quite interested in your last in the last slide, how we already have great ideas, yet translation and implementation are quite little in comparison. In Asia, or at least in the place where I work, I observe that there is resistance coming from clinical instructors in adapting the many concepts of medical education. It is still quite common for them to think that teaching is by instinct. How they were taught is how they teach. Would you mind sharing your experiences in advocating the translation and implementations of the CBME concept in medical education, in medical schools? Do they show resistance, thinking that this is too much of a hassle? Thank you so much.
Yeah, thank you for asking this. Resistance, again, have a look at implementation of great ideas. Resistance and slow adoption is the normal thing. That's the first thing I have to say. It's a normal thing. This applies to innovations in medical practice, to new therapies, to new diagnostics, except the only exception is if you say, if you use this machine and you get €1,000, then they are using this machine, but not thinking about the machine. They are thinking about the money. No, it is part of it. Therefore, is resistance. And science about implementation is also how to deal with resistance. For example, at the Charité, do not believe there was no resistance, and even yet there is resistance. And at the Charité, to really do this major change, it took three waves of really reform and revolution. It took at the end, it took 30 years that we get there, and there's a lot of resistance. How do we deal with resistance? First of all, you have to look for the right moment. You need leadership from the top, and you need a team who is dedicated. The next thing is, for those who are resisting, if you are in a change, you have to talk to them. You have to talk to them because in particular, in medical education, if somebody is resisting, he has also interest in medical education and he wants to do good things. And from those who are resistors, if you talk to them, and that's what we did, when we were talking to them a lot and we involved them, and we could convert 50% of those resistors, we could convert into those who are supporting us. And these are then the diamonds for the future change. But this is just one element. Implementation is their own science. I cannot learn within 30 minutes. It is their own way. It's like becoming a nephrologist. That's what I would say. Yeah. Therefore, if you experience resistance, that's a normal human behavior.
Thank you.
But you can deal. But if you accept that, you can deal with it and you can drive it. And finally, I must say, if you want to change something, it is. Let's put it this way: have a great idea to publish this in a big journal. That's a little bit of work. It's maybe half-year work and needs some good luck to get a paper published in academic medicine. But it's at the end, it's feasible. But it's a half-year work. To do change, it is doing much more work, and it takes years, and it's really a lot of work on talking.
Okay, thank you, Professor Ham. Any other questions?
There are two more questions,
there are 2 more
Prof. Titi
questions. Okay, we
and
still have
Prof. Peters.
time.
Yeah.
From Dr. Franciscus Cristianto, in order to start implementing EPA in the curriculum, can we create our own EPA statement, or should we use EPA statement from consensus at national level? Thank you.
Yeah. EPAs, for me, as somebody who's coming from the clinical background, are very tangible. They help. They are not the golden bullet or something, but they help, and they are much closer to the reality. And if you don't have EPAs, you have to decide. You have to decide whether you want to start at your own school or if you want to start nationally. This depends on the context. For example, at the Charité, we started developing our EPAs at our own institution because this was feasible. We had people to do this. We had experience with that. To start this at a national level, I'm also working at EPAs at the national level. This is a little bit more frustrating because at the Charité I had everything in order that we could develop EPAs as EPAs have to be developed and they look like. If you go into national level, then these committees, they have a different influence. Sometimes they don't have the understanding what EPAs are, but they have own ideas what an EPA is, which by definition is not an EPA, and so on. Therefore, you have to decide in what context and what people you can work with. The easiest thing is to start locally. And if you start, then do not start from scratch. Nowadays, in any field, you can see what others have developed as EPAs. Use this as a starting point and see how this would adapt to your context. And that's the one thing. Therefore, start from what is there, adapt it to your context. And context means to the task you have there, and the supervision levels, and the language which is in there. The language is very important, that you use terms which are understandable by the people who are reading this. I always say, if you write down an EPA, the student must, if they read them, they must understand what's in there. And even more, I say the patient, the student is taken care of, the resident is taken care of. The patient must understand what's in this EPA. Yeah, this is for that. Yeah.
Okay, thank you. One more questions from Dr. Siti Hadijah Ramania. Thank you very much, Professor Peters. As we know that to be competent, there are sort of multiple skills and knowledge students need to learn. What is your suggestion on breaking down those skills and knowledge in every study year to ensure that students don't feel overwhelmed, but keep integrating their ability until they finish their medical education? Thank you.
Yeah, this is how you scaffold from the beginning to the end. This needs experience and a special kind of experience. And what I can say, it is important, for example, if this is about medical education, that somebody who has experience by himself in the field of his own path in medical education, he is or she is one of the drivers of this change. Therefore, this comes from medicine. And if you are an educator and if you are a clinician, you have an idea where students are at a different stage, but you just have an idea. What we did when we developed our curriculum, we always did this together with students. Of course, not every student. These were the engaged students, and we had an understanding that they have a good understanding what they are able to learn at what stages. Therefore, we came up with ideas. We can scaffold this in this way, but they often refined this. They could tell us for each semester, for each year, they could say, we have not heard anything about this, or this is now too big challenge. And therefore, we did this in partnership with students, and we formalized also this partnership. Our students, they had full positions on the curriculum committees, and they got a little payment, and they had an equal voice, and they did a very good job with us. Therefore, the students, they are a biological probe. Yes, a biological probe, a real life experiment, which really helps to scaffold these things. And of course, don't make it static, because things are changing. Yeah. And for this also, we as the experienced lecturers and teachers, we are static in what we think, have students on board. They bring then in all the new ideas. And now, especially if artificial intelligence comes in, have students on board. What are they using this for learning, where it helps them learning, and what they think, how we can make assessment then valid and good.
Okay. Okay, thank you very much, Professor Peters. Any other questions? I think we have come.
That's all.
Okay, thank you. I think we have come to the end of our today webinars. Once again, thank you to all our distinguished speakers for the valuable knowledge and insights we shared today. Applause to all of them. I would like also to express our appreciation to all participants for your active engagement and thoughtful questions. So today's discussion, it is very interesting because at the beginning we have Professor Afina Supe explaining about global trends and challenges, transformations in medical education. Uh, there are 5 main themes: technology enhanced learning and AI integration, hybrid flexible learning modes, simulation based learning, interprofessional education, and CBME. And in the second sessions, we have Prof. Ova explaining about institutional readiness to cope with those global challenges. She talked about the need of having vision and strong leaderships to have curriculum integrations, faculty development, infrastructure, and investment, governance and ethics, as well as research and quality assurance. And in the third sessions, we have Professor Simon explaining about assessment in competence-based educations. She emphasized on the programmatic assessment, which is incompatible with great culture and high-stake exam. And lastly, very interestingly, we have highlights from Professor Peters that all big ideas that we have are in fact there is little implementation and all the challenges and the struggles in the implementation or in the translating all those big ideas into practice. Once again, thank you very much. This session really contributes meaningfully to our academic and professional practice. On behalf of the organizing committee, I sincerely thank everyone for attending, and we look forward to seeing you in our future academic programs. Wassalamualaikum warahmatullahi wabarakatuh. Good day and stay safe. Thank you very much. Thank you.